facial weakness since 3 days, slurring of speech for 3 days, and gait imbalance for 2 days. And on the day that she had presented to the hospital, she had a reduced sensorium, multiple episodes of vomiting, and came to us in gasping situation to the ED. She had a history of tooth extraction 12 days ago, and she was also known hypothyroid for 3 years. The history was given by the bystander, so there might be some incongruence with the side as mentioned by the history by the informant. On examination, pulse was 110 beats per minute, BP was 130 by 90, respiratory rate was 30, and the saturation at presentation was 50. Her GCS at presentation was 3 by 15. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, or pedal edema. There were no HCAS, there was no rash. A goiter was noted on examination. On respiratory examination was normal, CVS and abdomen were normal. On the CNS examination, the limited examination that could be performed, cranial nerves, bilateral pinpoint pupils were there, dorsal movement was present. She was moving all four limbs, and there was no neck stiffness. Plantars were mute. Patient was intubated and on muscle relaxant by that time. The next case is a 43-year-old gentleman who is the previous patient's husband. He had a low-grade fever for 3 days, right facial weakness with the facial numbness and a gait imbalance for 3 days. He had slurring of speech for 3 days and difficulty in swallowing. He had a history of travel to Salem about 3 weeks ago, and there was a history of swimming in a temple pond. And the patient's wife also had the same history. This gentleman, his pulse is 125 beats per minute, BP of 140 by 80, respiratory rate of 28 per minute, and saturation of 90. He had a congested right eye. There was dysarthria noted. His visual acuity is normal. There was a horizontal gaze paresis. Pupils, the right pupil was constricted, the left was thin, but both were reacting to a light. And there was upward gaze and downward gaze were normal. There was reduced pain and touch sensation on the right half of the face. Right element facial palsy was noted, and the uvula was pulled to the left. And the palatal movements were sluggish. The right was compared to the left, but his limb powers were normal, 5 by 5 power, all four limbs, and cerebellar signs were present on the right side. I'll just move. The clinical syndrome at the end of this was an acute onset headache with the multiple cranial nerve involvements in both these patients with an ataxia and a low sensorium, which the husband also eventually went on to develop. So the differentials here for a sequential development of multiple cranial nerve weakness with the presence of fever over a few days. The differential considered were brain abscess, skull-based osteomyelitis, and other inflammatory causes like acute disseminated encephalomyelitis. Given that both the patients had this and they had some history of exposure to travel to an outside place with the exposure to fresh water like a pond, we consider the infective cause more likely. And among the infective causes, the etiologies considered were bacterial, the ones considered pyogenic brain abscesses, tuberculosis meningitis with tuberculomas in the brainstem. Amyloidosis was another differential considered. Freshwater was there, so other causes like Naegleria and acanthamoeba were also considered. So going on to the basic investigations for the first patient, she had elevated total count with the neutrophil predominant, and her liver and renal functions were normal. CSF examination showed slightly elevated proteins with the lymphocyte predominant CSF counts on the cells. And her workup for viral PCR expert midget were negative. There was no history of fever, but since infection was considered, a procalcitonin was sent and it was elevated 7.05. And the other workup for brucella and toxoplasma were also sent and were negative. So next, the imaging was done for this patient to see why she had cranial nerve palsies. and a low sensorium. So it showed significant edema involving the right cerebellar peduncle and the right side of the pons, with cystic changes within it associated with diffusion restriction suggestive of abscess or developing abscess. The patient was hospitalized for a long time, intubated in an ICU. So, since the diagnosis was not being achieved, a brain biopsy, stereotactic brain biopsy was done, and brain tissue was sent for culture, and the GNB was identified as a Burkholderia pseudomallei for this patient. For the second patient, he also had a neutrophilic predominant peripheral count, and his liver and renal functions were normal. However, this patient showed a neutrophil predominant CSF picture with elevated proteins. And since there was history of freshwater swimming, a catheplepa culture was sent from the corneal scraping, and it was negative. The other workup was also negative. And this gentleman also, imaging was done to look for the cause of multiple cranial nerve involvements along with cerebellar signs. And his MRI brain with contrast showed a T2 flare. The images showed ill-defined, hyperintense, mildly expansive lesion involving the right cerebellar peduncle and the adjacent right cerebellar hemisphere. And superiorly, it had involved the right superior cerebellar peduncle and the right hemipons. Inferiorly, it extended up to the medulla as well. And there was also, what I'm not mentioned here and not able to show on the picture, is there was enhancement of the 7, 8, and 5 trigeminal cranial nerves. I would like to briefly mention about the epidemiology, when to suspect, how definitive diagnosis is achieved, the role of imaging and differential diagnosis when it comes to neuromyelioidosis. So the bug, as we all know, is the Burkholderia pseudomallei, and it occurs predominantly in a wet environment with is closely associated with rainfall. The major mode of spread is by inoculation of inoculation through cut wounds, or inhalation or aspiration, and also ingestion of contaminated water, as could have been the source for these patients. The risk factors, usually they'll have diabetes, or they could have a chronic kidney disease, or some immunosuppression, alcoholism, or thalassemia. In our case, the odd picture was none of them were known diabetics. However, the lady's GRBS at presentation was above 400, although her HbA1c was only 5.2. The mode of CNS spread is usually hematogenous, but it could also occur through the nasal route along the olfactory nerve or the trigeminal nerve. And neuromyelioidosis has a poor prognosis compared to the rest of myelioidosis presentation, where there's mortality of more than 20% of patients. Neuromyelioidosis accounts for 4 to 5% of all myelioidosis. So here I've just mentioned when to suspect. So this is a case, this is a paper published from Thailand, but they have collected all of the case reviews, case reports, and series that were available on the net till 2019. So here, the main thing I want to say is fever was a prominent feature in all these patients. And among the cranial nerves involved, cranial nerve 7 was the most common one to be involved. So, so if a patient has a fever, altered sensorium, and involvement of multiple cranial nerves, with a background history of diabetes or any other immunocompromise, or even as in this case, sometimes even when they're immunocompetent, we should have as a differential neuromyelioidosis. How is definitive diagnosis achieved? For this, I looked up 2 papers with the case series. One was from our hospital here in CMC, and the other from Delhi. And here, not all the patients had positive blood cultures. Some of them, we had to drain the abscesses from other places, such as the brain or the epidural abscess, or from other places like some of these cases had psoas abscess, splenic abscess, which were drained and the organism identified from the same. But we need to have a microbiological evidence to call it a myelioidosis. So the role of imaging, the most common imaging finding in CNS myelioidosis is the cerebral abscess. The propensity to involve and extend along the white matter tracts, basal ganglia, and trigeminal nerve. So one of the classical findings is that there is a tunnel sign, which is an involvement of the corticospinal tract with a linear tract-like enhancement of the corticospinal tract. So some of the differential diagnoses to be considered in patients with neuromyelitis from the imaging point of view will be a tuberculosis, but the things that differentiate is there's more predilection to basal cisternal spaces, whereas the neuromyelitis involves white matter tracts, cranial nerve involvements, which is more common than in TB. Neurobesets is another differential as far as imaging is concerned. However, history of fever and the travel history can favor neuromyelitis, and the association with HLA-B51 and HLA-B5 can favor neurobesets. Asparagonosis, which is a parasitic infection, can also have a tunnel sign indicating a migration of the live worm. However, the CT shows hyperintense lesions, whereas in the neuromyelitis, the CT will show hypointense lesions. Now, so back to our patients. Patient 1 was treated with meropenem and doxycycline. However, current functional status is she's a quadriplegic, completely bedbound, but able to communicate only through eye blinks and understanding commands. And she's on tracheostomy and Ryle's tube. The second patient was also managed with the meropenem and for the intensive phase, and the meropenem is still being continued for more than 8 weeks. And he's also on doxycycline as part of the eradication phase, but he's in a persistent vegetative state with central hypoinflation syndrome with central dysautonomia. And the patient was taken to another hospital on meropenem.
Thank you. Any questions or comments from the audience?
We get a history of steroid use, either homeopathy or they've used alternate medications, or they've gone to a doctor for fever and had steroids. More than a lot of patients who are not diabetics, there's often the steroid use. We've had a couple of women who kind of survived it despite it being in the brainstem. But there we gave infusion, meropenem as a higher dose and as an infusion, along with doxy right from the start as injections. Because he said it's a more severe and sicker patient. So those patients have survived. But we had mortality as well.
The first patient, the ear examination was okay because she had left-sided dental extraction, hearing, headache, hemicranial headache.
That's probably not because he's not seen the patient. See, the findings were all on the right side, the opposite side. So that was the confusing thing. Though she had a dental extraction, so ear also was normal and the mouth also was normal. And second thing is there was no history of steroid use. They're actually CMC patients and they're from Ahikam, so they actually consult only the physicians. Both are educated people; they're not uneducated or like. What we wanted to highlight is a typical finding because once the patient CT MRI was done, the radiologists were able to tell this is neuromyelitis. The difficulty was getting a microbiological culture. And I agree with Dr. Sudha that all myelioid patients should be treated with IV infusion meropenem and trough levels must be sent. That actually makes a huge difference in the outcome. So that is what we did for both our patients as well. The thing is, because we saw this case, the next week another patient came. And the patient was transferred from Narayani in a vegetative state. The MRI here showed the same findings. So quickly we started on meropenem. Actually, now he is all right. So this is to say that we learn from cases. So when some people survive, when some actually do bad things.
Thank you, Ahikam. Next, we'll move on to medicine 3. Rahul.